Hi,
There we are.
hi,
Hooray! That was my first
hi.
live connection.
Bit nerve fighting. So sorry, I'm a bit late.
That's
Good to
okay.
good to speak to you.
Oh,
Yeah,
it's very good to see you. You're a busy lady. I imagine it's
yeah.
been a busy day.
It has been. Yeah, yeah. Absolutely. Not helped by the fact that my social media team have just changed the password to it. So I was
Don't you love
thinking,
technology?
oh my God, I was thinking it worked last week, but then it didn't work today. And
It
I actually
sends.
thought, and I actually thought about signing in on my personal one, and I thought that that could go badly wrong. So
That will
anyway,
throw me. That would have
yeah,
totally thrown me. I was
yeah,
going through the names thinking,
yeah,
I know she's in here somewhere.
yeah.
Anyway,
No,
how
but we
are
got
you?
there. We got there.
We
I'm
got there.
good.
Well
I'm
done.
good. Yeah, yeah,
Yeah,
yeah.
good. So, Miss Henderson, I know that you are a doctor, but I've been told by your team you go by Miss Henderson. Is that correct?
I go by whatever. I mean, I'm Scottish, and in Scotland being the more egalitarian country, if you believe that, all doctors, surgeons, GPs, everybody goes by the name of doctor. Even if you're a neurosurgeon or a gynecologist, you're not called Mr. or Miss or Mrs. In England, and I believe in Wales, surgeons, including gynecologists, as well have the name Mr., Ms., or Miss.
Right.
And everybody else, a physician, a GP would be a doctor. So I'm used to being called anything and everything.
I just
Yeah,
wanted to get it right. That was all, because I
yeah,
know it's important. And so you are the owner of the Amara Clinic, which I
that's
understand
right.
is a very successful menopause clinic. Do you
That's right.
want to tell us a bit about your journey coming to that? Obviously, you've come from Scotland and your clinic is based in Tunbridge Wells.
It is, yeah.
Yeah.
So I trained down in England, hence I've worked most of my career down in England. I did my medical training at Cambridge, and then I trained at Guy's and King's, a couple of the big London teaching hospitals, for several years. And I was really fortunate to train under Professor John Studd. Now, people in this generation have probably never heard of him, but if you go back 10, 15, 20 years, he was he was a huge name in menopause. And when I worked with him, we were doing research, not just into menopause, but into perimenopause, PMS, PMDD, postnatal depression.
Right.
And what brought it back full circle to me was, if you have any listeners and participants who are interested in this kind of thing, there was a huge Scandinavian study which was published a couple of weeks ago, looking at hundreds of thousands of women who had a possible history of perinatal depression, and the link that that then had with PMS, PMDD, and perimenopausal depression.
Right.
I mean, to me, that has been my career journey. And even when I was a junior doctor working with Prof. Studd and his team, we knew there was a link. We knew back in the 80s and 90s that there was definitely a link between hormonal fluctuations and mood disorders. And it's fascinating now that in 2024, there's this huge study that has come out, and it's almost as if it's a revelation, as if we never knew this before. But if you look back at the papers that we published years ago, my own particular MD was in postnatal depression and looking at using transdermal estrogen to treat postnatal depression rather than antidepressants.
Oh,
It was
wow.
phenomenally successful. We did a randomized placebo-controlled study looking at the role of estradiol patches, which are still around today, and it's one of the reasons that you created your kit. We did all our randomized research using estradiol, and the results were amazing.
Wow.
For PMS, PMDD,
Yeah.
but there was something about it that just wasn't politically correct at the time. Psychiatrists had a stranglehold on management of postnatal depression, postnatal psychosis. I think less so today. And I think there are many more enlightened psychiatrists today who who actually acknowledged that everything isn't down to serotonin, and postnatal depression isn't always down to your partner or your husband or your upbringing or your birth. Do you have PTSD? All of the things that keep getting trotted out. There's a huge number of women who have perfect partners, perfect lives, great deliveries, and they still get the most profound postnatal depression. So it's very difficult to blame those cases on circumstantial events. It's just fascinating to see that the data that we had in the 1990s, it was published in the Lancet. It's almost like the cycle comes round and round. I was very fortunate back in the day to have that amazing training. Sadly, there isn't anybody like John Studd available nowadays, and most junior doctors are, struggling to get through the week, let alone thinking about taking time out to do postgraduate research. So we were very fortunate. And then after that, I went on to run numerous NHS menopause clinics as a junior doctor and then as a consultant. When I was an NHS consultant in Kent, we had one of the biggest menopause NHS clinics in the southeast. We would see hundreds of women a month. We were even offering implants under the NHS, which nowadays is just an anathema. We were fortunately, we had funding and we had support, and we were able to offer a great service. And then more recently, over the last 9 years, I've been running clinics in the private sector. And as you mentioned, I set up the Amara Clinic 18 months ago. We've been open for 18 months now.
Gosh.
And we're about to expand into a second clinic, which is really exciting.
Where will that be based?
It's great. Well, it's a stone's throw from the Amara. We're in the Pantiles in Tunbridge Wells, and those of your listeners who know Tunbridge Wells, I mean, the Pantiles is just amazing. And now that we're coming into spring, it's bursting into life, and it's just such a great part of Tunbridge Wells to work in. So the second clinic is going to be in Rust Hall, which is on the outskirts of Tunbridge Wells, and it's we literally took it over about 6 weeks ago, so the refurbishment is underway. We're aiming to be open late September, but I think I think looking at the work, it's probably going to be a Christmas opening. But
Gosh, you're taking it on, aren't you? Running one clinic, getting another one opened.
This one has 10 rooms, has an operating theatre, and it's going to be a collaboration with the Private Clinic Group in London, which is an amazing. They have their own business, so we're going to be collaborating. So we're going to hopefully have a one-stop clinic with my services, women's health, menopause, non-surgical cosmetic treatments, nutritionist therapy, physiotherapy, mental well-being, CBT, you name it. We're hoping to have it all under the one roof.
Wow, that sounds impressive.
So it's a lot of work to do, but it's a really exciting development, and it's already underway, so we're just
good luck.
Absolutely.
I hope it all goes well. We have lots of questions coming in about ladies with patches, and I know that you cover a very broad range of the menopause, not just about patches themselves, but I understand, I don't know if it's an NHS thing and a private thing, that the patch tends to be a first line treatment as opposed to the gel, or would you say it's
my first love was Estradot, which is still 25 years later the gold standard patch. So the one thing I would say to the audience is beware the patch that you have. They're not all equal. It's like comparing a Fiat with a Ferrari. Seriously. And the
I'm
funny,
feeling a bit Fiat-like with mine.
well, I mean, I'll probably have the lawyers on my back by tomorrow. I can't remember the last time I prescribed Everel Contier, Everel Sequi. I can't abide Everel or Estroderm or generic patches. I'm very loyal to the brands that I work with. And I did all my research with Estradot. We did our PMS, our postnatal depression research. And the reason that we chose that over and above Estrogel is because, firstly, the compliance that we had from patients, it's much easier to put on a patch and change it twice a week than it is to rub on gel laboriously, 10 minutes every day, you know.
Yes.
I mean,
And in
who's
the
got time?
winter, when it's cold,
Oh,
you're stood
God.
there with all this wet gel on you, star
Or,
jumping.
or even, you know, we've got clients in the clinic who live in very humid climates, you know, Middle East, Far East and beyond. And, you know, they're already hitting 40 degrees. And, you know, the minute you go anywhere outside air conditioning, the gel literally just melts off your skin. I mean, it doesn't travel well.
No.
So Estradot is amazing, and it is patented. It has a patented adhesion system, hormone delivery system. That's why it's this size, whereas other patches are that size. So don't believe anybody who tells you they're all the same. They are not. They may all begin with E, Estradot, Everel, Estroderm, but they're not all the same. So I mean, one of the things we have at the MR is we're very picky. We only work with 2 or 3 different products, which people are astonished with, because if you look at the British National Formulary, I think there are 300 and counting forms of HRT.
Right.
But most of them are just not worth even considering.
I have to say, though, sorry to interrupt, but I was prescribed Estradot, and I know that a lot of ladies are making the same comments. I can see them coming through, that you can't get it for love nor money. They're like hen's teeth where I live.
So you can. So it's a myth. So I accept that last year, 2023, there were shortages. It was very patchy. And the reason is that Estradot is made in the US. It's not made in Europe or the UK. It's got nothing to do with Brexit or any of the nonsense that's been talked about. It's not anything to do with Estrogel or Utridest. And they're made by Bessans, which is a French company.
Right.
So all of Estradot is manufactured in mainland USA. Okay. And they have one factory which, due to popularity, was already working 24 hours a day. And then obviously they hit problems. You know, the minute you have to have machinery maintenance or you have an FDA inspection, you have to shut down. So there were definitely limitations on production.
Right.
But last year, the license was moved over to another drug company who I think are much more proactive. They really want to expand the brand. They want to get it into all NHS pharmacies as well as private pharmacies. They realize they have gold dust available. I mean, there is absolutely no comparison between Estradot and Everel.
So are you saying then that as an NHS patient, you should be able to get Estradot? Because my pharmacist says cannot get it for love or money.
Well, look, we can get it at the Amara, and if we can get it, and you know, we're not doing illegal bartering or anything. If we can get it, NHS pharmacies can get it. The problem is that the large chains like Boots and Lloyd's, and they're not interested in most cases in prescribing and providing the best product. They just want to get the HRT out there. And if there's something that's more available, like Everel, for example, or the generic patches, they're slightly cheaper, they're more available, that's it. And we don't work like that. And if you look around and you do a bit of detective work, you'll find that local independent pharmacies, often family run, will be able to get Estradot very easily. And even with branches like Boots, if you have a prescription that says Estradot, that's what I want, they have a duty of care to the patients to get it.
Mm-hmm.
It may take an extra few days, but if you put your foot down and you say, I don't want a generic patch, I want what I want, which is Estradot, they will have to try and get it for you. And
Okay.
the availability this year is phenomenal. We work with Pharmacy Irish, which is a major London distributing pharmacy, both online and in person. And they have availability of virtually every strength. 75 goes in and out a bit, but everything else is available. So I would beware what people tell you.
There's going to be a lot of scared pharmacists tomorrow. I think there's going to be a wave of women saying, I want Estradot now. So
I mean, you know, this is one of the things that I hate about menopause and HRT prescribing. The elephant in the room is that all products are equal, and that is nonsense. It's not the same in any sector, you know, whether it's a food product or a facial product or a car or anything. It's ludicrous to say that, oh, everything works the same. And HRT isn't any different. And I know because, and I feel I can say this from a point of strength, because we did all our research using Estradot. Every single piece of research that we churned out in the 80s and the 90s was based on Estradot. And my view is you go back to what the research shows.
So can you give us an example? So I've got questions coming in saying, what are the differences? So what would Estradot deliver that maybe Everel doesn't deliver, for
completely
example?
Different. So if you look at the matrix of the patch, you've got most generic patches are this size. Everel is this size.
Mine's huge.
It was described as the postage stamp patch. Now, it can't, if you just look as a layperson, if you look at the bioengineering that has gone into producing a patch this size that delivers 100 micrograms of estradiol reliably, it's phenomenal. And this is not new engineering. This has been around since the 80s. It's ridiculous to say that a patch that is 4, sometimes 5 times the size, it has a completely different texture. The patch matrix has a different feel, a different appearance. Anybody who's worn Everel versus Estradot will know that Everel and comparable patches have this slightly crinkly feeling. I mean, I actually had a patient the other day in clinic who was moving, and she said, "Oh God, I'm rustling." You know, and I thought she was talking about my seats. I was going, "What?"
It leaves folds in my skin when I take it off.
Absolutely. She said, "No, it's my patch." And she said, my husband gets fed up with it because he's convinced he can hear it rustling in bed at night, you know. And I thought, well, maybe he's a light sleeper. but you know, any of those of you who have tried Estradot, it's just like a second skin. There's no noise, there's no wrinkling, there's no crinkling. It doesn't lift. You don't get that nasty condensation feel under the skin that you get with the other brands, because they don't stick to the skin like that. They lift slightly and you get condensation, sweat building up under the skin. And the point about a patch is that in order to work, it has to be completely flush with all the skin at all times, 24 hours a day. If you don't have that, you have not got reliable hormone delivery. And that's why many women on the other brands, I mean, we're not just talking about Everel here, we're talking about anything other than Estradot. That is why they often experience fluctuating hormone levels, ups and downs. Many of them end up changing the patch after 2 days rather than 3 or 4, because the patch is already sliding off. It's because of the matrix and the adhesion. They're not the same.
And then also at the other end of the spectrum, I know, because Amy, my partner, she has Estradot. She peels hers off and the glue wipes off beautifully with our product. I take mine off and it's like super glue underneath. It's a real challenge to get that off. I mean, it does come off, but it's not like the Estradot experience. So yeah, that's interesting.
So
okay.
I mean, my view is that the perfect combination, and what we advise, is Estradot plus your pack, your nudie pack, because then you've got the perfect blend. You don't have this aggressive sort of scrubbing removal using acetone, alcohol based products and so on, but it's a great patch, so it's relatively easy to remove the residue, and
Yes. So
it's a great patch.
we've had quite a lot of ladies say that they're getting sort of a reaction to the patch. The skin's becoming a
Yeah,
bit red and angry underneath.
yeah.
And a pharmacist was saying to a friend of mine today that is it that it's the alcohol in the patch? Is there alcohol in the
No,
patch? And if you
it's more complex. So all transdermal products by definition have to have alcohol. The patch, the gel, Estrogel or Sandrina, or the Lenzetto spray, they all have alcohol, because the mechanism that if we go into the sort of pharmacodynamics, the way in which the estrogen is released into the skin and then into the bloodstream is by evaporation of alcohol. So it's a complete fallacy to say that only patches have alcohol. And alcohol, of course, can be very irritant, particularly for women with sensitive skin. And of course, perimenopausal and menopausal women tend to have more sensitive skin. But anybody with eczema or psoriasis, but it's all about the type of alcohol, the quantity, concentration, and so on, plus the glue. Now, the one difference that patches have over spray and gel is the adhesion, the adhesive nature. And again, Estradot has a patented delivery system and a patented adhesion system that is different to the other patches. And because it's got, it's not, put it this way, if other manufacturers were able to copy what Novartis did with Estradot, they would be doing it. They would be. Nobody's going to be manufacturing a patch this size if they can manufacture a patch that size, just because it's, it's much better.
And so I've got a very hot question that keeps coming up, that why does it have to be below the belly button, and does it matter? So I stick mine sort of on the ovary area, because I think there's more to get through round on the sort of buttock and the hip area. So I think, oh, maybe it'll go into my bloodstream quicker on my front. What's the thinking behind that?
Well, the idea behind applying it lower down is largely mechanical. So one of the reasons that I don't like people applying patches on the buttocks or the thighs, well, particularly the buttocks, is if you said to somebody which body part, which muscle is always being compressed or irritated or under friction or moving, it's the buttock. So if you're climbing stairs or you're walking, the glutes are moving. If you're sitting down, you're rubbing against a chair or a sofa. Thighs the same. So to me, it's madness to put any medical product anywhere near an area that's constantly moving. Why would you do that? I mean, you even if a product is struggling to get hormones or drugs through the skin, if you give them an additional challenge, you've got to do that whilst I'm sitting on the tube or climbing an escalator or running or exercising. Why would you do that? So there's a huge logic to applying products like a patch on the abdomen, because in our lifestyle, very few women are constantly using the abdominal muscles unless they're doing crunches or they're specifically exercise.
Not here.
Well, but you just think about your daily activities. You use your glutes and your thighs all the time, unless you're literally completely sedentary. So there's a logic to having the patch in an area where the muscles aren't constantly doing this and the skin isn't constantly doing this. The reason that we recommend doing it lower down is simply friction. If you do it higher up around the belly button or umbilical area, you've got tights, you've got leggings, you've got trousers, you've got skirt waistbands. You're constantly pulling up and down. You go to the loo, you change your clothes, you have a bath. You're constantly pulling clothing up and down.
Is there a safety element though as well? Because I know one lady said she put it on her arm, and I thought you weren't supposed to have it sort of in the breast area because of the cancer risk.
My view is the traditional teaching was always low abdomen, in the bikini area, above the hairline, so you get good adhesion. And then the idea is you can look down, you can see the patch. If if there's irritation or it's lifting or it's come
Yes.
off, you can see it immediately. I mean, if you have something on your butt, unless you're looking in the rear view mirror, it could have come off and you wouldn't know, you know.
True. Yes.
You know, and I've had so many patients over the years who partners have said to them, didn't you used to have a patch there? You know, and they go, oh, is it not there?
It's gone. It's stuck
But
to my husband. Yeah.
well, that's it. The funny thing is, the men go, "Oh my God, is it on me?" You know, they're not bothered about the menopausal flushes and sweats. They just think, "Oh my God, I'm going to be, you know, suffering from estrogen overload within half an hour." You know, it's ridiculous.
And what about the rotation thing? So I was told don't keep putting it in the same place over and over. So how does that work?
So it doesn't matter whether it's the spray, patch, or gel. The good advice is you rotate. Skin doesn't like constantly having an insult applied to it 24/7.
No.
So with patches, you rotate left to right, and I would always say, you know, you can see the little mark. Even with Estradiol, you see the little mark. You clean it off. You don't go back on that spot. You go to the other side, then you go back again, and you try and move it around a little bit. You know, shake it up a bit, just to give the skin a release from having the patch there. It's the same with Lenzetto. You know, if we've got Lenzetto going on the forearm, if you're right-handed, there's a temptation to always apply it, you know, to the left arm. That's not a good idea because of the alcohol content. So I always recommend that patients shake it up. The gel's the same.
So with the patch, you think it's okay to go left, right
Definitely.
in the same? Yeah. Yes. Oh, that's good, because I've been trying to do 1, 2, 3, 4. You know, a hip and the abdomen and rotating round. So that's fine.
I just think it's not logical to put patches on a body part that is constantly moving or under pressure or friction. And so I would say always the abdomen. Now the downside with the larger patches, one of the reasons I believe that they are recommended to go on the buttock or thigh is because they're much larger. So if you're quite petite or you know, you're not particularly tall, you know, to get a sizable patch on your lower abdomen, it's not cosmetically very attractive, and it can actually be quite uncomfortable when the patch is crinkling and you're moving around. So I think that is why larger patches have had you know, the general advice is stick it on the butt or the thigh, but you know, my view is that's not the way I was trained. That's not the research that we did, and I feel much more comfortable with the abdomen.
Okay. And what importance would you say there is in terms of removing the patch, an old patch, before you put the new one on? Because we have had some ladies who have sent us photos and videos where they had multiple patches, old ones, and I thought, is there a residual dosing risk there?
Absolutely. Yeah. I mean, you know, the 2 words that come to mind are off license, and the one thing that HRT needs to be careful that we don't stray into is off license. And so for the lay public, that means there is no research, there are no guidelines about off license treatment, and so one needs to be really careful about what the risks and benefits are. Now, the patch does not suddenly run out at day 3 or day 4. The studies show that even if you look at day 5 or 6, for most patches, there will be a residual hormone delivery effect, particularly for estradiol, because it literally clings like a second skin.
Yes.
So, but that is not what the guidelines suggest. That is not what the scientific studies reported on, and that is not what anybody like myself would recommend doing. Because the one thing that you want in HRT above all else is constancy. You want consistency. You want your estrogen to be like this, your progesterone and your testosterone.
Yes.
You do not want peaks and troughs of any of the hormones. That is what causes side effects and symptoms. It causes peaks and dips and mood swings. So the same with the patch. It is licensed for use with 2 patches a week. No more.
Right.
So you might want to change a patch every 3 days. Some patients do, because they do find that on day 4, the hormone levels dip very slightly. So we've got patients who choose to change their patch every 3 days. I'm happy with that.
Yes.
But for most patients, a day 3 and a day 4 change is fine. The minute you start to apply more than one patch at a time, you are in a territory that has not been explored. There are no guidelines about safety, breast cancer risk, hormone delivery, anything.
Okay.
And I would say absolutely do not do that.
Okay, so
do not
I've got somebody asking, what if you're a poor absorber? Would that be something that might be an exception if that's been tested? No.
So poor absorption is a red flag. And it's one of the if we call them the elephants in the room with HRT.
Right.
Now, and I think it's under-recognized, it's underdiagnosed. We see it all the time in my clinic because we do rigorous blood levels. And if you follow patients up, check their clinical response and their blood levels, you will pick up the women who are poor absorbers.
Right.
And often they're poor absorbers with the spray and the patch and the gel. They just have a genetic inability to absorb transdermally, and that might go for other drugs through the skin as well. We're not just talking about estrogen. I would say those women should not be persisting with transdermals. They need to move on to an alternative route. And in my view, that should be a subdermal implant, because the subdermal implant just gets beyond all the transdermal nonsense. It gets the hormones, estrogen and testosterone, into the subcutaneous tissue, which is in the end what the patch and gel and spray are trying to do. But it does it, and it's not down to compliance. It's not down to genetics and how you can absorb through the skin. We see too many women who have tried 4, 5, 6, 7, 10 pumps of gel. They've tried multiple patches. They're on 6, 7, 8 pumps of Lenzetto. It's madness. That is not scientific practice. That is straying into very difficult territory.
Right. Okay.
If you cannot absorb transdermally, you need to draw a line and move on.
Try something different. So I've got a question here saying, what about those who've had the surgical menopause who need a higher dose?
Yes, absolutely. Yeah.
So
absolutely.
They may have wear more patches, or you think they would?
Of course, yes. Yeah. So again, with Estradot, you can do that easily because you've got 100 microgram this size. If you wanted a 200 microgram patch, you've got that skin area. Whereas with the other patches, you can end up with your whole abdomen covered in patches to get the same delivery. It's not sustainable. And again, the original research that was done looking at PMS and PMDD looked at a 200 microgram patch equivalent, which is double the maximum dose. But we were licensed to use that. We got amazing results.
Yes.
And that was with 2 100 microgram Estradot patches on the abdomen, changed twice a week, and it worked like a dream. And it's perfectly true to say that many women having a premature or a surgical menopause do need higher levels, and they may well need multiple patches. They may need to go off license with 100, 125, 150, 175 or 200 patches. But obviously that needs to be monitored very closely. But there is.
I was just going to ask you that. People are asking, how often should you be reviewed? Do you become sort of not immune, but do you build up a tolerance to estrogen patches? Is that something that you should review regularly?
I don't think it's a tolerance, but there is a titration process when HRT is first onboarded, and it's exactly the same with any medication, whether it's thyroxine or insulin. Remember, menopause is an endocrine process. There are huge similarities with other endocrine conditions. And what happens is you introduce the replacement, the body soaks it up, it's fantastic, you feel wonderful. Then the levels plateau because the receptors are saturated. So that's great.
Yes.
But then the receptors are saturated, but the levels start to drop because there's been an initial massive absorption, because it's like I mean, I explain to patients, it's like watering your garden after a drought.
Yes.
You know, within an hour,
I like that analogy.
The grass
Yeah.
looks a bit greener, the soil looks a bit browner, and that's wonderful. And you can see the plants and everything perking up. But 3 or 4 or 5 hours later, everything's gone a bit flat.
Yes.
Because that water's been absorbed and you need more.
Right. Okay.
And that's exactly what happens with HRT. So if you're doing it in a scientific way, you onboard, you measure, you monitor, you then titrate further, you measure, you monitor, you titrate further, you measure. And that can take 4 to 6 months.
Yes.
And then usually you reach a plateau where you've got 80 to 90% symptomatic improvement. And then you go on to maintenance, which is exactly what it says. You're maintaining blood levels, symptomatic control, you're monitoring side effects. It's all part and parcel of managing HRT properly.
Yes.
Sadly, the NHS probably does not have the resources to do that.
I was just going to say, you're lucky to get an appointment, and let alone have your bloods measured. I've got loads of questions are coming up. I'm trying to keep up with them all. But how would you know if you'd had too much estrogen and maybe needed to lower your dose?
It's difficult. I mean, if it's been, my argument would be that if you're the doctor prescribing, or the nurse or pharmacist, you know, we have, you know, multiple prescribers nowadays. If the person prescribing knows what they're doing, you should not end up with excess treatment, because the onboarding is very important. And you get to the sweet spot. That's what we're trying to achieve. There, as with all medicine, moderation is the ideal. There is never any benefit, in my experience, from having an excess of estrogen or progesterone or testosterone.
So there wouldn't be any obvious signs, like you wouldn't have breakthrough bleeding, or
you may have that, but you more likely, before you get that, you might have mastalgia, which is breast pain and tenderness, bloating, even breast enlargement, fluid retention, even nausea, just feeling generally a bit out of sorts.
Okay.
So an excess of estrogen generally doesn't make you feel great. You feel a bit blah.
And in terms of how long we should all be wearing patches, you know, I'm on my 52 this month. Will I wear this forever, or
probably?
Yes.
Yeah.
Oh, okay.
So I mean, there's a lot of nonsense that gets circulated, which you know, is just to someone like me, it just makes me livid. You hear these little tales, you want the lowest dose possible for the shortest period of time. There is no scientific paper ever published looking at HRT that came up with that conclusion, and yet somehow that got drafted into GP guidelines, MHRA guidelines. It's twaddle. It's absolute twaddle. If you are on a modern body identical HRT regime with natural estrogen derived from soya, natural progesterone generally derived from yam, so we're talking about utrogestan, the risks of breast cancer are virtually negligible. There is no risk of thrombosis. There is no risk of high blood pressure. Bowel cancer rates are reduced. Osteoporosis rates are reduced. Cardiovascular risks are reduced. Possibly dementia is reduced. Longevity is increased. End of. So there is no logic that says you should stop at 55 or 60 or 65 or 70. In the clinic, our oldest patient's 93.
Oh, wow.
She has been on, I mean, and she's like a 70-year-old.
How fantastic.
She's been on HRT for 50 years, so more than half her life. She drives, she does charity work, she does Sudoku, she does the Times Password. I mean, some of that's genetic, but some of it is definitely
that's impressive.
Down to HRT. And her GP, she keeps calling a boy. A boy. Well, if you're 93,
it's all relative, isn't it?
He's probably in his 30s, but he's a boy. And it was funny. I had a conversation with him a few weeks ago, and he said, "Goodness me, she's a challenge." And he said, you know what, I met her twice and I thought, I'm going to stop telling her to stop her patches. It's never going to work. And she told him that she is going into her coffin with her patches beside her, and they're going to be incinerated with her for the afterlife. And I said
That's
to him, I
so
said, look,
funny.
that's great. I said, that's just agree, just
Yeah,
agree.
what a role model. Okay, that's great. So I'm just going to get my head into that zone now. That's where we're going to go.
You know,
So just, I know I'm conscious of the time, and I feel like I could sit here and talk to you for hours, but I know you're a busy lady. We heard through the jungle drums that there was a testosterone patch
yeah.
that was being trialed. Is that true?
Well, yes. And I'm, much as I would love to welcome new forms of HRT, I'm a bit skeptical. I mean, I haven't got any personal knowledge of it, but we had a testosterone patch about a decade, 10 to 15 years ago. And it went through all the usual formal drug trials. It was released, it was available through the BNF, and it was a car crash. It just did not deliver the punch that women needed.
Oh, what a shame.
And it lasted about 18 months, and then I think my understanding is it just folded. Now, if we can get a patch that delivers the sort of punch that we get from Androfem, for example, which I would say is the gold standard available,
Yes.
then bring it on.
Yeah.
But my concern is, firstly, what size is it going to be? And we've got to remember that you just can't ladle patches on menopausal women. There comes a breaking point where, if you're somebody who's on a double patch, because let's say you've had a surgical menopause and you also need testosterone.
Yeah.
And I appreciate this is an extreme example, but you could literally have a whole abdomen covered in patches.
Oh.
How sustainable is that? And if somebody's in their late 30s, early 40s, they're going to need HRT for a minimum of a decade or longer.
Yes.
Do they honestly want to have their whole body covered in patches? My view is that I think there is definitely a role for the tiny discrete patch like Estradot.
Yes, definitely.
But I think women like having a mix with a gel and a patch. They don't really want to have bodies completely plastered in patches.
No,
So,
I'm just saying from a personal perspective that testosterone is the one thing I forget most days. So the patch is always there and I change it twice a week. And I don't always remember to do that. And then you kind of feel a bit like, oh, low energy, what's missing? And then I remember.
So there definitely that. I mean, the compliance with patches is one of the top recommendations. So listen, if it's a good patch, if it's good quality, if it doesn't irritate, if it's small, and if it delivers the levels that we need, brilliant, bring it on. But the downside, the elephant in the room with testosterone is it's all off license. So until the MHRA acknowledge that hundreds of thousands of women in the UK at the moment are being prescribed testosterone off license, if they don't think that's a significant risk, that's a big worry to me. The sooner we bring testosterone under regulation, as we have with estrogen and progesterone, and educate and train GPs and practice nurses about how to prescribe, how to monitor levels, that's what we need to do. At the moment, it's one of those things that it's nothing to see here. We haven't licensed testosterone, so who's bothered? But the problem is that many people are bothered. Many people are prescribing it. And it's all under the radar.
I didn't know that.
It's utterly ridiculous. It's such a big red flag. And the British Menopause Society have been raising this year on year, and just getting pushback from the MHRA.
Why do you think that is then? What's the resistance there?
Discrimination. It's partly discrimination, and it's a carryover from the last 20-30 years, where the bottom line is, and I can say this because I've been doing menopause and you know, I've been involved in menopause for 30 years. Most of the time, nobody gives a damn. Middle-aged women are not a priority. They're more of a priority now. But when I started my research in the 80s and 90s, nobody gave a damn.
No.
You know, there was no education and training of GPs or gynecologists for decades. And it's only really, I would say, since just before the pandemic and after, that the clamour from you know, influencers and media personalities, as well as the general public, that is what has driving training of GPs and doctors and the colleges. You know, the Royal College of General Practitioners, my college, the Royal College of Obstetricians and Gynecologists, for decades, no funding went into any kind of menopause training or education. It was shocking.
It's so disappointing.
I mean, you know, I can go back to when, you know, I did my research, and, you know, John Studd was a huge character. He was larger than life. But he was not, there weren't many of him. There was just him, and everybody else was nobody was interested in menopause. No. And when you think there are 13.5 million women during perimenopause, menopause and beyond in the UK, and probably a third of those are still in the workforce.
Yes,
it's disgraceful. I think it is discrimination. However you want to call it, it's the discrimination. Absolutely.
Oh dear. Yeah, it's all a bit depressing, isn't it? But anyway, let's hope that somebody in the media will champion this one for us, because it does make a difference. I can say from personal experience that using testosterone in conjunction with estrogen really does make a difference.
For some women, it's a game changer.
It is,
and women, what I love about being involved in menopause now is the people who come to see us, the women who come to see us, are referred. They either self-refer primarily, or their daughters or their sisters or their friends or their husbands, their partners, their sons. They refer them, you know, and they're looking out for themselves. They're not, sadly, as somebody who trained and worked in the NHS for decades, they are not depending on the NHS anymore, because the NHS has let them down. It let them down massively.
Which is a real disappointment.
It is a shocking story. But there is so much education out there now that women can, you know, do their best to self-educate and then decide, this is what I'm going to do. You know, I will do the best that I can for myself, and if my GP or the NHS can't provide, then I'll go where I need to.
Absolutely. I'm conscious of time. I've got one last question, if that's okay with you.
Yeah, sure.
Because we advertised this was patch related. Obviously, many of us are parents to young women, and we understand that there's a contraceptive patch.
Evra.
Right, I've not heard of this before.
They've got all the same name.
Yeah, but it doesn't seem to be very well known in this country. I understand it's big in Spain and other countries in Europe. Is that something that will come to the UK?
Well, Evra's not new. It's been around for years. Now, some of it, I think it's a cultural thing. And I mean, I have discussed it with some of our, I mean, obviously we do gynecology as well, women's health in general. And I often offer it to younger women, and they don't want it. They don't want to have a patch on. They feel self-conscious. They don't want to be saying to people, I'm using contraception, I'm on the patch. I don't know if it's a generational thing, or, you know, if there are other issues to examine. But I can understand that, you know, if you look at what the current younger generation have to contend with, perhaps the last thing they need is a patch on them saying, I'm using contraception. And one of my patients actually said to me, and I think this is a really important take-home point, she wasn't, you know, she was aware that she was on the pill, but she also didn't want her partners to know that until she was in a stable relationship, because she wanted to use barrier methods, quite rightly.
Yes.
And she said, if I have a stocking great patch on
Yes.
me, he's going to go, well, why do you want me to use a
It's
condom?
like a red flag, isn't it?
Exactly. You know, and the minute she said that, I absolutely got it, because I was trying to sell her the benefits of transdermal hormones, and she said, but you know, why would I want to tell a guy?
Yeah, that's a good point. I'd not thought of that.
You know, I said, absolutely get it. But then that is a generational thing, because when Evra first came out, we perhaps didn't have that you know, that dialogue going on.
No,
I mean,
right.
women just didn't want to get pregnant. They didn't give a damn how they did not want to have an unwanted pregnancy. That was it.
Yeah.
Now it's much more, I don't want a pregnancy, but you know what? I don't want chlamydia. I certainly don't want gonorrhea or God knows what else. And I don't want, you know, I'm not even going to go there. I don't want HPV, you know.
Yeah.
So I think the current generation are much more switched on, self-aware, and a patch is a patch. You know, when you're stripped naked, you can't hide it.
No,
you know?
It's a bit like, hi. I know.
So, but you know, apart from that, Evra is a brilliant contraceptive.
Yes.
And you know, there are definitely benefits to transdermal treatment that you don't get with tablets. But I think there's more of a story to it, which I think is you know, it's a fascinating discussion to have.
Yeah, definitely. Well, you've been absolutely inspiring today. Some of the messages are saying I've learned more in this half an hour than I have from any of my GPs and my private appointment. So you've been an absolute inspiration. And I'm hoping that we can, because some of the questions that are still coming in are
send them over.
Well,
I mean, if you send them over, I'm very happy to
that's
do
very kind.
what I can.
Yeah, some of them will be things that we covered at the beginning. So hopefully if I can work out how to share this on our feed, then it will be available for everybody. But I just wanted to say, Miss Henderson, you've been amazing and so informative and inspiring. And the Amara Clinic, if you were in Tunbridge Wells, I'd be popping in and coming to see you. But I'm in the Cotswolds. So sadly, you're
we do virtuals as well. So
oh, do you? Oh,
we
brilliant.
do. We
Fantastic.
do virtuals.
Well, thank you so much for your time. You've been fantastic, and enjoy the rest of your week.
Well, we love listen, we love the product. You know, we're stocking it in the clinic, and
I'm just going to show it.
It's I've got my own pack here, actually. I haven't, but it's great. And prior to using this, we were recommending patients use things like Zoff, which is a little alcohol wipe. But you know, this is much gentler. You know, all the stories of coconut oil. I mean, you can't, because you end up with this greasy film, and the patches don't stick.
We tried all of that ourselves, and you get it all over your hands, and you can't stick a patch to it. Yeah.
But anyway, you know, one of the drawbacks definitely with patches is the residue they leave behind, and what do you do with it? And you know, I think if you can overcome that, then the patch, you know, there's a no-brainer. You know, I think for most women, patches are probably up there in the first or second choice. And you know, if you can get Estradot, so much the better.
I'm on a mission tomorrow. My GP and my pharmacist are not going to love you.
Oh, well, you want to get
Estradot.
your prescription. You get your prescription, and you go around and you phone round and you march around like, you know, a militant menopause, and I want my Estradot. And actually, you will find pharmacists who will bend over backwards to help you. I mean, we've got several in Kent. They're the little niche pharmacists that there's almost like a network of patients who go there. You know, these are the pharmacists you want to support, and they will get Estradot for you.
I went away for Easter and I was begging my pharmacist for Everel. He said, Estradot, forget it. Everel we're out of stock of as well. And it was just an absolute frantic bum fight. I was driving around trying to find anything.
The other advice is go to Ibiza, because I had a patient who came back from, I know it's a bit random.
I'd love to. When are we going?
I had a patient who came back from Ibiza and said she literally bought another suitcase on the island, because every pharmacy had every strength. and you don't need a prescription. And I thought, my God, please tell me you didn't tell them that I was your gynecologist. You know, I'll be getting arrested. And she literally came back through the airport with a suitcase full of Estradot. God knows what she's going to do with it. But there you go. If you're going to Spain or Ibiza, you can get your Estradot.
I can already hear the conversation I'm having with my husband. It's a girls' trip to Ibiza because of the medical reasons.
Apparently, I have it on good authority. They all stock Estradot. So
excellent.
There you go.
Oh, that's brilliant.
Great.
Thank you so much. You've been
lovely
absolutely
to speak
great.
To
yeah, you too.
All
Take
the best.
care.
Bye-bye.
Bye.
Bye-bye. Bye.